So this is a very high level. I mean, we could talk about this subject all day long. We could go on for hours and hours, but we only have an hour. I'm not going to say wait to the end to ask questions. You have questions, raise your hand, shoot it out, you know, blurb it out, however you want to do it. But this is a very high level macro look down on AEM. We're going to go over the statement that Joint Commission CMS made, and then kind of dissect that, talk about that a bit, and then towards the end, I'll get into what we do and how our program works. But at any point, we can do a deep dive into any of this stuff. So just raise your hand if you have a question, and we can dissect as much and as long as we want. I will ask a favor though. Somebody could just let me know when we get to about 10 minutes before. That way, if there is something that I haven't covered yet, you know, that I want to touch on, I at least get the chance to do that. So, all right, we'll get started. So I work for WakeMed Health and Hospitals, and before any presentation, we always go over our missions, our Wake Away behaviors, and it may be a little bit hard to see, but we have a pyramid, and at the very top of the pyramid is patient and family. Everything is obviously centered around that. That's our whole business. Making sure that patients are safe and the families are taken care of, and everything's working properly, and they leave the hospital hopefully with a good outcome. We talk about being a value leader and all these initiatives that you know, AEM covers, eliminating waste, creating efficient flow, just-in-time processes, commitment, accountability, all that stuff. So whoa, she wasn't kidding. And that's it. Any questions? Yeah, she said this thing would skip ahead. All right. Who am I? I'm Seth Blanchard. I have 18 years of success as a data-driven, growth-focused program project leader. I've been in the healthcare, some sort of healthcare capacity for over 20 years. But as a leader for about 18. I've been at WakeMed Health and Hospitals for 10 years. And one of my big things is I love to identify and drive innovative opportunities to accelerate daily processes, strengthen vendor or partner relations, empower employees, and eliminate sources of risk and waste. Looks good on the resume, right? And then above all, loyal and committed to patient safety. So that's what this is all about. WakeMed Health and Hospitals, that's a 3-hospital, 1,000-bed healthcare system. We're a nonprofit system. We have 7 emergency departments, a dedicated children's hospital, 80+ physician practices, over 8,000 employees, and we work out of Wake County in North Carolina. My department, good group picture there. We got 22 employees across 3 hospitals. We manage 31,000 plus devices. Our operating budget, not accounting like service contracts and all that, about $12 million. And a little pat on the shoulder, we won the North Carolina Biomedical Association Shop of the Year twice, the only hospital to do that. So, all right, let's kick into it. What is alternative equipment maintenance, AEM? So this is pulled out of CMS and Joint Commission. So they state, in the United States, the Center of Medicare and Medicaid Services requires that healthcare facilities maintain, inspect, and test all inventoried medical equipment in accordance with manufacturer's recommendations or with strategies of an alternative equipment maintenance AEM program. With some exceptions, an AEM program allows a healthcare facility to adjust its maintenance, inspection, and testing frequencies and activities for facility and medical equipment from what is recommended by the manufacturer based on a risk-based assessment by qualified personnel. Right, a lot of stuff to unpack in there, and we're going to get into all that stuff. So that's the statement. That's what came down 8 years ago, and we all read it, and we were all like, okay, what does all that mean? What are they talking about? So why would we go into an AEM program or establish an AEM program? Like I said, that makes people shift in their chairs a little bit when they read that. So provide safe maintenance practices. That's the most important reason. That's what we do. So why do I say that? So why do I have the audacity to put that as my first bullet point? how does AEM provide safe maintenance practices? All right, everybody take a cup of coffee, take a sip. So AEM, we're talking about doing a deep dive into equipment, into the maintenance practices, into looking at past histories. We're not, you don't have to take maintenance away from a device or reduce maintenance. You can actually add maintenance, that you can add steps to a PM program if you think that that's what's safe. So it's you know, that's the common thought is, if this device is on AEM, it means we're not doing PMs on it. Well, no, maybe you're doing more to it, adding more steps, adjusting the schedule, making it a little bit narrower. So that's what we do. So we're trying to provide safe maintenance practices. Also, in the other slide, I said I have 31,000 plus devices, and I got 22 employees to take care of all that. That's a lot of work, you know. So if AEM can help reduce some of that, then that is a safe practice, because now we're working on the stuff that we deem needs to be worked on instead of what the manufacturer may mandate. Any questions on that? Yes. Yes, absolutely. And yeah, no, definitely. You don't have to take. You can take notes, but and what I'll do is I'll leave a bunch of my cards up here. I got more too. So grab a card afterwards, shoot me an email, give me a phone call, because like I said, there's a lot of information to unpack. We only got so much time, and but stop me at any point, ask questions. So the other thing is reduce costs, PM parts, vendor service, contract reduction. So obviously, if we're eliminating some of the work, we don't have to buy as many parts. We don't have to hire a vendor to come in and help us out. We can reduce contracts. Reduce labor, it's a big one. Free up time for other task projects, process improvement initiatives. What's a big thing going on, you know, in the last few years? Cybersecurity, all that stuff, you know, so we have to have some time to be able to take on these new roles. COVID, you know, all that stuff bubbles up that we can't plan for. So to be able to free up some of your time by reducing labor is definitely a plus. PM completion rate, a few years ago, Joint Commission decided that instead of a 90% non-high risk PM completion rate, we have to have everything at 100%. Retention, improve morale, let people take PTO. We're not jamming work down their throats. Trying to create a healthy home work-life balance. Provide time for technical training. Let them go off to school. And then, most importantly, Joint Commission said we can do it. All right, so I said we were going to unpack that initial statement. So the first line was, in the United States, the Centers for CMS required that healthcare facilities maintain, inspect, and test all inventory equipment. So I highlighted all inventoried equipment. So the FDA states that medical equipment is any medical device from a tongue depressor to a bedpan. So how many of you all have tongue depressors and bedpans in your inventory, right? So there's a broad term. So all inventory medical equipment. So you have to have a standardized inventory. You have to be able to determine what you want to put in your inventory, or what makes it in and what doesn't make it in. And that needs to be established in a policy, and it needs to be clearly defined, and everybody in your department should be able to understand what is and what is not included, and why. Why did you make that decision? Device category and model cleanup. This was the big one for us when we started this AEM program, our process into it. It took us a little over a year to go through and standardize our device categories and clean up our models. If I wheeled in an ESU in here and I asked each one of you what you call that, I'd get ESU, electrosurgical device, electrosurgical unit, OV, you know, all those terms. So so you have to be able to come to one common naming scheme. How many have access to their CMMS where they actually edit and add, delete models and devices? Yeah, a couple of you. Are you the only ones that have access to that? You are? Nobody else can do that? Nobody else can edit? Good. All right. So it's good, and it's, you know, but if you're on vacation or whatever, somebody else can do, you know, somebody else may need to do it, but it is good because you only interpret what you know. So nobody else is interpreting it differently. So model cleanup, that was another big initiative. We have, I'm not going to say the vendor, but we have a radiant warmer, infant warmer, as an example. And one warmer has a scale in it, and one warmer has a blender in it, and one warmer has a scale and a blender in it, and one doesn't have any of those things in it, but they're all that model name. Are you going to have different PMs for that model? Right, obviously. So you have to be able to standardize that model. And what we use is the reference number, because that reference number will change, you know. So instead of calling it, you know, well, I'll say what it is, it's a Panda. So we have GE Pandas. So instead of calling it a Panda, everything can't be a Panda. It has to be the reference number defining what's in that device. And there it goes. Hold on. I might do it from here. Technology. All right. So one good thing Joint Commission gave us was 2 categories, high risk and non-high risk. Years ago, we had 7 different categories to determine our risk level of a device, depending on what it was, where it was used, who was using it, if it was in a wet location, surgical area, an ICU area. But they came out and said that you can categorize things into two different risk groups. So it's either high risk or it isn't high risk. Thank you. You know, that made life so much easier for us when we were building out our CMMS and defining what was under AEM. Standardized maintenance checklists. You have to, if you are going to put a device on AEM, your technicians need to know what steps you're taking. What are you doing differently? If you're adding steps, you have to make sure that technician A and technician B are doing the same thing. In our CMMS, we created a rule that for all our PMs, we could put in our checklist. So whatever we decided was the PM, it was a checklist, and you can't close out that work order. You can't hit close unless everything's checked off. The PM has to be completed. So if there's an issue with it, you would put, you know, yes or no, you know. So we have yes, no, we have pass, fail. We even have categories where you can put numbers in there. So if you're doing a centrifuge PM, you can put, you know, the RPMs that you have, and it has to be within a certain tolerance. So you have to have a standardized maintenance checklist that all your technicians can follow. I'm gonna hit this here. Proper documentation. So in your CMMS, we always get it. We get the device comes down, or you get called up on the floor and it's broke, right? That's the description, broke. Well, you got to define it a little bit more than that, right? So you got to say what's broken, how did it break, you know, get as much information into your documentation as possible. And then when you put in what you did to the device, tell a story, tell that repair story. Don't say fixed it and returned it to service. What did you do to fix it? All that information is used when you're looking back on this to needed for evidence-based assessment to decide whether or not, you know, an AEM needs to be adjusted or removed or added, you know. So all that information is needed. And so legal documentation, you have to have proper documentation. Clear department policies for device inclusion, risk category, and AEM inclusion. So like I said, your standardized inventory, you need to have a policy that clearly defines how you made that decision, right? And then your whole team needs to know how you made that decision. Same thing with risk categories. How do you categorize something that's high risk and non-high risk? They are Joint Commission, CMS, AEM, they don't tell you that. You have to define that on your own, but you have to be able to understand why and how you made that decision. And then same thing with AEM inclusion. Why are you including something into your AEM program? And I got policies that I can share with you towards the end. I'll share with you a little bit of that, but this is one good thing about this field. We're not competing, right? I'm not competing. I'm not trying to take your patients, and bring them to my hospital and all that. We can collaborate. So I have no problem sharing policies with you guys. You guys can even take them and put your name on them. I don't care, this is a collaboration. This is, I want to learn from you all too. So if you have a better way of doing things, please let me know. But yeah, I have no problem sharing any of that policies, how we decide all that, which we'll touch on in a little bit too. So once you get all that into your CMMS, you need to identify the devices that are on AEM and non-AEM. So how are you doing that? Are you putting a suffix? That's what we do. We just put, AEM infusion pump, AEM, defibrillator or whatever, or the model, AEM this, so that if Joint Commission comes and they say, what devices do you have on AEM, you can immediately run a report and show them. Same thing, the high risk and non-high risk should be doing that. Some people aren't still, but you should be in your CMS clearly be able to define what's high risk and non-high risk. Sure. Why does what matter? So good question. You need to be able to, so that is a good question. I don't know. Anybody, yeah.
Joint Commission surveys will focus on that category, so you need to be able to define it. I think it's also assumed that you're using high risk versus non-high risk as a way to prioritization work. But really the survey question is what we have.
Okay. Yeah, okay, that makes sense. But yeah, great point. It really, if I was in Joint Commission, I'd probably, yeah, yeah, it's a good point. Yep. Great question. I love that. Never thought of that. All right, and then you need to have a means to continuously monitor and analyze predictable and preventable failures, PPF. It's not, once you decide something's on AEM or you included a device, you don't just close the book and say, all right, it's on AEM, I don't have to worry about it anymore. You have to continuously monitor and analyze, are you making a negative impact or a positive impact? Maybe no impact, but you need, oh, I forgot. Technology. Yep, that's where we are, right? All my notes down there. I can get to see. All right, so that was the all medical devices. I want to make sure I didn't skip a slide though. Let me go back one. All right. Yep. All right. So let's unpack this part. So it says, with some exceptions, an AEM program allows a healthcare facility to adjust its maintenance, inspection, testing frequency and activities for facility and medical equipment from what is recommended by the manufacturer based on a risk-based assessment by qualified personnel. Again, one sentence, a lot to unpack in there. So I highlighted with some exceptions. So this is straight out of Joint Commission in CMS. Devices that cannot be placed on an AEM program include those that have a specific maintenance requirement imposed by federal, state, or local law, imaging, radiological devices, medical lasers, and equipment for which you do not have sufficient maintenance history to support inclusion in an AEM program. So those things you don't even have to worry about. That's a chunk of your inventory. We're not even going to discuss it. They don't allow it. So any questions with any of that though? So don't put those on AEM. Your imaging devices, your lasers, and then things without sufficient maintenance history, which we will touch on too, because that's one of those broad, loose terms. They don't say, you know, things that have to be in your inventory for 2 years, 5 years. They just say, you have to have some sort of maintenance history. All right. An AEM program allows a healthcare facility to adjust its maintenance, inspection, and testing frequencies and activities for facility and medical equipment from what is recommended by the manufacturer based on risk-based assessment. That's a long sentence. So risk-based assessment. This is straight out of CMS 2. So this is how they want you to assess risk and how you should assess risk. So records provided by the hospital's contractor. So if you have service contracts, any of those service reports, you got to make sure that they're going in your CMS tied to the device. Somehow you got to be able to track that. Use that information in order to determine, you know, whether a device should be AEM or non-AEM. Information made public by nationally recognized sources, so your FDA, your manufacturers, alerts, recalls, MedSun reports, things like that. Those should also be attached probably into your model records, so you have a record of any issues that some outside sources, a nationally recognized source, has alerted you to, and then your own service and PM work orders. Over time. So that's what allows you to base your devices on a risk category, or, you know, whether or not to include it in based on some sort of outside influence risk or internal risk. And then qualified personnel. This one's always a seat squirm or two. People shift around a little bit. So qualified personnel. So in order to be a biomed, what do you need to be qualified? Are you all certified? Do you have to be certified? Do you have to have some sort of certification? Now, in CMS states, in the case of medical equipment, a clinical or biomedical technician or engineer would be considered qualified. Very broad, very loose. If you're hired into a clinical engineering department, HTM department, whatever you call it, you're now qualified. Whether you like it or not, that's the way it is. I have some reservations and thoughts on that too, but you know, that's what they state. It does go on to say certain devices, you know, you should, it doesn't even say required, but that you should have somebody trained maybe in a manufacturer's technical training course. So you don't want to just stick somebody right off the streets and put them on an anesthesia machine. You know, they should have some sort of training on that. What I will tell you though, Joint Commission may ask, you know, for employee files and folders and, you know, information on their training. So make sure that if you are a manager or a leader, that you have all your technicians training documentation somewhere. And if you're not a leader, make sure that you are supplying your management with that information and they are keeping that somewhere. All right. What time is it? 10 o'clock. So I said at the beginning, FDA said that any tongue depressor, bedpans, anything that is deemed medical, or those things are deemed medical devices. However, Joint Commission, thank you, also helped us out to kind of define that a little bit more. So they say medical equipment, fixed or portable devices used for the diagnosis, treatment, monitoring, and direct care of individuals. So I said I would have kind of share our policy. So in our policy for our inventory inclusion, we have a decision tree, and it's just, like I said, it's yes, no basis. So that's how we can define whether something's included in our inventory. Makes it really easy. Joint Commission loved it when they came and they took a look at that. They said that it's a really good idea, and it leaves out a lot of interpretation. So if I think something should be and my director thinks it shouldn't be, we can run it down this decision tree. Does anybody have anything that they are a little iffy on or falls in a gray area in their hospital, medical device wise? Does everybody work on beds? No, yes. So yes, you're shaking your head. Yes, you're shaking your head. No. So, I mean, that's how you define. It's not, Seth said this device should be in your inventory. It's how you define it. And they give us the autonomy to do that, which is really good. But yeah, so there's a lot of gray area device. Sure.
So how do you deal with things that are small and portable and might not require any maintenance? So we leave off some things like some of the iStats or glucometers, partly because they're impossible to keep track of. That's not a good reason.
Right.
Inventory them. So how do you deal with those things?
So Joint Commission allows you to have a one-line item in your inventory that states we have X amount of glucometers, and it doesn't even have to be the actual number. It can be a rough, they say a rough estimate, basically. So if and it's worth maybe once a year as a PM to check with your point of care or whoever manages those and say how many glucometers do you have on site. But they do allow you to have a one line. You have to have it in the inventory, but it doesn't have to be serialized. You can just say, we suspect we have 200 glucometers. So let's see. So let's do a little example here. Anybody have any device that they want to put through this? Oxygen flow meter. All right. So I know it's hard to see, and you guys can get this presentation after, I'm sure. If not, I'll email it to you. But the first part, let me see this. So up here, so if you put in the oxygen flow meter, ask 4 questions. It says, is the equipment used to provide direct life support? Does the oxygen flow meter provide direct life support? No, right? Does it deliver therapy? Right, yeah, does it? It actually delivers therapy? So this is the interpretation part, right? This is where it gets difficult, yeah. So I see you shaking yes, you shaking no. How would you define therapy, delivering therapy? It's delivering, okay. Okay, so. Yep.
But other techs would say, okay, well, we want to increase this to 70% O2.
Okay.
And once that patient starts recovering and getting better, then you lower it back to 21.
All right. Anybody think it doesn't deliver therapy? All right, so then right here it says yes, and then it included in your MEMP. So it's included in our, that's how we run through that. Anything else? Anything that even more gray than an oxygen flow meter?
You're saying if it applies therapy, it should be OEM.
Seth's saying that. Seth's saying it should be in your inventory. Yeah, Seth's, I'm saying that's how WakeMed decides. I'm not saying that, you guys have your own way of doing it. But an oxygen flow meter, we do include it, and we include it sort of like our glucometers. We just have one line item. We talk to respiratory care. They say we have X amount, and that's what we put in there. So, so I mentioned beds because I saw some say yes and some say no. So let's see. Let's run a bed through. Does a bed provide direct life support? No. Does it deliver therapy? Right? Yep. Some of them don't, right? Right. All right. So the ones that do, we include. Yeah. The ones that, that shake you. So those we do. The ones that don't, so stretch. All right, let's talk about stretchers. Does a stretcher deliver therapy? No. Does it gather diagnostic information? Nope. Does it monitor physiological conditions? No. So then, no. So then it drops us down into the next category here. Does the equipment control a bodily function? No. Does it deliver a drug or a nutrient? No. Does it require an invasive connection? No. Does it provide for sterilization of clinical devices? We put that one in there because all sterilizers need to be inventoried. So we make sure we capture sterilizers by doing that. So no, so then it drops you into the next box there. Does the equipment require electrical power to function? No, stretchers don't. Is the equipment used in a patient care area? Yeah. So yes, brings us down into here. Does one of the following apply? Can the device directly impact patient outcome? So whether if they're on a stretcher or not, no. And then device represent a significant patient risk? No. And then so no brings you back here. Does the device meet the definition of medical equipment but is otherwise considered non-high risk and or run to fail? And I would say no. So it wouldn't be included in. All right. Yeah.
Could you have something that does not meet the criteria, but you choose to inventory anyway because you want to schedule it?
Yep. Yeah. So, and it doesn't show it here, but in our policy, everything's up to our director, to make a final decision on whether or not something should or shouldn't be. We just use this tool to cut out a lot of the fat. All right. So that's how we include stuff in our inventory. And then, like I said, you also want to have a policy that defines whether or not something's high risk or non-high risk. And we do the same thing. We have a flow chart for that. And I apologize. I wish it was a little clearer. But we can, anybody have a device that they want to run through, see if it's high risk or non-high risk? Nothing? No? It's all sip on our coffee again. AED, okay. So is the device used for critical resuscitation? Yep, so it's high risk. Pretty easy, right? Any gray area ones? ESU, okay. Is the device used for clinical resuscitation? No, so that drops us into the next box, which is right here. Does the device maintain life? No, no. Does the device, wow, this is blurry. Does the device deliver high energy directly to the patient? Yep, yep, boom, high risk. All right. Yeah.
Do you still go through this process even if the manufacturer states with a letter stating that it does not require any maintenance?
Yeah, I mean, yeah, and I'll tell you why in a second. It's part of that, the timeline. You have to have something in your inventory for so long to determine whether or not it's, it should be included or not included in AEM. I do say that we don't do a PM if it doesn't say, not to do a PM because there's nothing to do it on. But we watch the history and then decide whether or not we want to include a PM. Maybe there's something that we've noticed that we want to do more than what the manufacturer states. And there are devices in our inventory that like our Defibs, we replace the battery before the manufacturer states that you want to replace the battery just because we had some battery failures. So So I mean, it does add some work, you know, but the majority of the stuff we reduce some of the work. Any other device want to run a high? Yeah, sure. Yep, it's AEM. It's an alternative maintenance plan. It's something going away from what the manufacturer says. So yeah, we have documentation to support that. No other device? All right. So then we decide whether or not something should be in the AEM or non-AEM program. So let's talk about, what did you say, Defibs, or AED. So what WakeMed has decided is 2 years. That's our defined timeline. So something has to be in our inventory. A new model has to be in our inventory for 2 years for us to have enough information to make that decision. That's not written anywhere, you know, outside our policy. That's what we decided to do. Some people do 5 years, some people do 1 year, some people don't have it defined, but you should have it somewhere defined what that looks like to you or what it should be. So an AED, does the device, the first one is, does the device have less than 2 years of maintenance history? If we say yes, it has less, then it's non-AEM. We're doing whatever the manufacturer says for those 2 years to gather enough information. But if it's not, if it's something that we've had for more than 2 years, the next one is there a regulatory requirement mandate or a particular level of maintenance? So like CAP, AABB 21, CFR, all those requirements. If it doesn't fall into that, are there backup units or alternate methods in place used in the event of device failure? So why do we say that? So why does that determine whether something should be AEM or non-AEM? So if you have a ton of backups, does that help support maybe pulling something off the floor or pulling it out of your AEM or putting it on an AEM program? You can, you know, if it does run to fail, instead of having to do PMs on it. So we decided that that's a factor. And then the next is analyze AEM data. So then we go through the history, make sure that between PMs, we don't have a ton of service reports, because that's what I look for. You know, if I have a PM 15 service reports before the next PM, then we should probably maybe even add another line to our PM or reduce the timeline. But if not, if you just see PM, you know, 1 year PM, 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 and your CMS history, then maybe you can include it in your AEM. And then it kicks it over to, does the data support change the non-AEM status? So if we say yes, the data supports it, then we have it, drop it down into the AEM thing. Anybody have a device they want to run through this? I mean, except for the history. Yeah. Sure.
You mentioned about other sources of requirement for additional.
Yeah. So CAP, that's your lab. Your lab has their own certification processes. Your rehab, if you have a rehab hospital, they have their own. I think it's CARF. Yeah. So CARF may decide that, you know, that device has to have this PM done by the manufacturer within a specific timeline. You know, so we can't go away from what they say. Yep. Oxygen blenders. All right. So let's say we'll use your hospital. So have you had that model that you're looking at for more than 2 years? Okay. Is there a regulatory requirement on oxygen blenders for you? Yeah. What? Yeah. DNV. I mean. Yeah. Okay. And DNV states that you have to do that. Okay. Oh, okay. All right. So so let's say that you're not, and then do you have enough backup blenders for that model? Yeah. So if one goes down, it's not like it. Yeah. Then you go through, you analyze the data, you see between your PMs, what that service history looks like. If it warrants going to AEM, put it on AEM. If not, then you don't have to.
One question.
Sure.
Been a while since I read the literature, but I think I recall there being similar model, similar make model scenarios to be able to place something on.
That's,
AEM.
yep.
And the blenders, for instance, some are the Secret's 3500 L,
Mm-hmm.
3500.
Yeah, and the birds, they look like this, you know, yep. So there is a statement in there where if you have a like model, if it's built similar, you know, a similar model, you can use the data from that like model to represent that model too. Same thing, same internal. Yep, yep. So yeah, it does. They did help us out with that as well to be able to find that. Any other questions on any of that? Does that make sense? Is that, you know, do you guys do anything similar to that? No. All right. How do you, people that do have an AEM program, do you have a policy on how you decide what makes it into your AEM? No. That's, I mean, how about high risk, non-high risk? Do you have a policy that shows? Yeah. Okay. And then obviously your MEMP, I would hope everybody had one of those. All right, so how do you track those devices that you decided that you want to put on AEM? You've gone through the whole, you know, you go through the whole decision tree like we went through. It's been in the AEM program for a while. How do you track the maintenance history or whether or not something needs to fluctuate or come on or come off PM, add a step, maybe take away a step? Anybody doing that? No.
With the Volo taking over, obviously, and that's hard to get as good as full.
Is it? Because we're about to go to Nuvolo. Yeah. Okay. Right. So one good thing about Nuvolo, and I'm not a vendor. I don't, you know, I'm not saying go to Nuvolo or anything like that. We don't have it yet, but we did sign on with Nuvolo. We're using an antiquated, we use Mainspring, Accruent Mainspring, but they're about to sunset that in December. So we're kind of forced into going into something. But I am looking forward to it because what I do know about Nuvolo is you can build it however you want it. You can put in rules and all sorts of stuff. So I'm really interested to kind of do a deep dive in that. And I know there's other vendors out there that have similar platforms. But yeah, I am really looking forward to, I'm an analytics guy. I love data and all that. Data drives everything. All right, so what we did though in our Accruent CMMS is we created a rule similar to the procedure steps for PMs so that everybody's doing the same thing. It's all standardized work. You have to, before you close out the work order, I won't let you do it. You have to answer 3 questions. And the first question, and this is for every single service work order, PM work order, even incoming inspections, which really doesn't make sense. But what I want is I want my technicians to, you know, focus and to remember these questions and to really think about it before they just start clicking no, 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 you know. So the first question is, and this is mainly towards service report or service unscheduled work orders, but it does also for PMs. I do see a few PM work orders that have yes answers on this, but again, this is just yes, no. I'm not asking anybody to write a story on any of this. It's just whether or not this happened or didn't happen. So the first question is, was failure predictable, i.e. PM related calibration drift, a PM related battery failure, or a PM related component failure? So if we have a device that's on AEM and it comes down because the filter's clogged up, because we're not changing filters anymore, you know, then somebody would say, yes, you know, that was a predictable failure. We should have been changing filters. Same thing with batteries. Probably should be changing batteries. You know, they're going to fail. So anything that has a shelf life, you should be changing it out. or doing some sort of maintenance on it. Second question is, would a change in the PM frequency or addition to the PM schedule have prevented this failure? So if we had a device that we are doing a PM, would a change in the frequency of the PM? So if we shorten that window, would we have caught this failure? So if that's how we determined our Defib batteries, we're gonna shrink the window down because we were seeing, I was getting a few yeses on this. Or in addition to the PM schedule, so should we put that device on a PM schedule? Even if the manufacturer says no PM, you know, should we do it? It's up, they're giving us the autonomy to make that decision, which I love. You know, it's the whole right to repair, you know. And then the last question, would a change to the PM procedure or the addition of a procedural step have prevented this failure? So, so should we add another step? Should we take away a step? Any questions on that? See the value of doing something like that? So what that does is it kicks out a report immediately. I'll immediately get notified an email pop up and it'll say, you know, somebody answered yes to this, and I'll look it up and see what the model was and all that, and then start seeing, all right, you know, do we have other technicians saying the same thing? And I've caught a lot of devices and made a lot of changes, and it's constant. I mean, there's rolling into an AEM program isn't just, all right, we're going to do this and then, you know, that's it, and we're just going to let it ride. And you have to, there's a lot of work that goes into it. However, that front end work hopefully produces, you know, less work downstream, and safe work. So they've allowed us to do this for about 8 years. And I think if it was a big failure, they probably would have taken this away from us by now. But I think people are doing the right thing when they are doing this. We're not leaving a wake of injured and dead patients behind us, right? I mean, it's, so any questions on any of that? Yes.
So how often do you review the answers to these? Is that part of your annual review, or do you do it more?
Reviewing, so if I get a yes to one of these?
Or like enough yeses to, you know,
Yeah, so it's, yeah, so once a month, I'll go through I drop everything into a spreadsheet. But I get these, you know, so often that usually I can catch on to, like, you know, hey, we have this one model that everybody's answering yes to the last 3 weeks. You know, let's do a deep dive and figure out what's going on with it. But at least once a month, I'll pull up that spreadsheet and I'll weigh everything and see, you know, if a change is needed or not. I do get again, it's interpretation. Interpretation kills AEM programs, and it kills inventory inclusion, and it kills, you know, standardizing your model, your device category, because we just saw it when we were running through the flow sheet, the decision tree, that some people think yes and some people think no to certain things. So so it's the same thing. I have one technician that may say yes, you know, they think an additional step should be added, and then another person will see the same issue and think no, you know, it shouldn't be. So that's why you have to have a long, you know, we do 2 years, but you should have some sort of history so you are capturing as much information as possible and trying to eliminate some of that interpretation. Anybody doing or know about Lean Six Sigma? Yeah, so yeah, standardization, I know it's starting to kind of kick up in our industry. Virginia Mason, I think, was the first hospital out in Seattle to start that. And we're a big proponent of Lean Six Sigma. So everybody has standardized work, you know, everybody answers these same questions, everybody has the same checklists on PMs, you know, trying to eliminate variation. That's,
Were you able to share with us any of your bulk items that WakeMed take in the manufacturers requires plant maintenance and you can move to an AEM?
sure. One of the ones, this, you know, this is another seat squirmer, are infusion pumps. We do not do PMs on infusion pumps. So They're high failure items. The ones that we use are gravity fed. The tubing goes through teeth. There's no way for a free flow. It's impossible. The only way it's if you don't load it correctly, and that's not, we're not going to catch that in a PM. That's a user issue. And we ran those. So when I say 2 years, that's our bare minimum, right? So those I think we had it on for 5 years because we had so many and we wanted to make sure we got this one right. So 2 years is our bare minimum. Anything under 2 years, we don't even look at, we don't pay attention to, I don't care about it. Once it hits that 2-year window, then we can start looking at whether or not the data shows that something should be brought on. But yeah, so infusion pumps, we change the battery out in those every 5 years. That's the only maintenance that we do. Have not had an incident. We run, I think we have 2,300 infusion pumps with no negative patient impact, and we've had those on AEM for 3 or 4 years now. So saves a lot of time because those PMs were, I think they were 45 minutes average or something. You have to, run it for 20 minutes and then make sure that, and we never saw any fluctuation. They were accurate, so no need. But a lot of people are like, oh, infusion pumps, holy mackerel, how that's crazy to not do a PM on those. But they tell you, and we're starting to see that more and more in our field too. You turn on a device and it tells you what's wrong with it, right, before you really have to get into it. Another one that we do is our patient monitors. We're a GE house. We use we have some old dash monitors and stuff like that. We don't do a PM on those. We don't even change the battery on those. Well, so let me back that up. They don't use those for transports. Those are on the wall, plugged into emergency power. If I change the battery, right? We do get calls though, because they'll get the message saying battery, dead or low or something like that. And we'll pop in another battery. But let's see, another one that I told you some of our defibs we've added a step to our some of our ESUs, some of our ESU models. We've added an additional step to those. Yeah, I don't know. Does anybody have an example of anything that they put on AEM? No?
We kind of did the same thing with infusion pumps, but I just took over as manager, and so I was going through the documentation. The old manager doesn't have anything.
Oh, yeah, yeah.
So I didn't know. That's the question. What example of documentation, what would you need to have for joint commission to show?
So we show, all of our service histories, all these questions. I have a, a spreadsheet showing all this, but we can pull up if they say, why did you decide to do that? I can run a report with all our service, report, service checkouts, those things, and show them, it's all broken down. You can, parse out, if it was a drop failure, if it was, somebody didn't load the tubing right, or a clean point needed to be cleaned out or something like that. But yeah, you can pick out different terminologies and show how many we had. But when you have, the good thing about infusion pumps is we have so many of them. So even though the number may look big, like holy mackerel, you had 40 clean load points, in 1 year, but out of 2,400 pumps, it's really pretty significant or insignificant. So I said at the beginning, we have close to 32,000 devices. If we were doing a PM on every one of those, or not everyone, but if the manufacturer's recommended PMs, if we weren't running an AEM program, that'd be about, we're trying to figure it out. We came up with like 17,000 devices we'd be doing a PM on, and we've cut that down to just under 7,000. So we're only doing PMs on under 7,000 devices. A lot of work that we took away. Now we can focus on cybersecurity and other areas that we deem is more risky than doing a infusion pump PM. So, yes.
So do you have some that you're still doing PM on, but you've pared down the procedure?
Yes. Yeah,
How do you document?
so we have our same thing. So I can run a report and show that we haven't had a failure on, let me think of an example. Oh, I'm sorry. We haven't had an issue with IV pump. We haven't had an issue with what do you call it? Accuracy, flow accuracy, right? Everything checks out all right. So we take that line right out of our PM. So we can show in our standard checklist that, yes, we've had yes answers for those, for 2 years, 3 years, and now we don't do them anymore. Does that make sense? Yeah.
When you make those adjustments to the program, you take that to the UC committee for approval, or just simply as they approve the policy procedures, internally make those?
Yep. Exactly it. Yep. Yes. Sure. Baxter. Again, don't go back to your hospital and say, Seth says we don't have to do PMs on Baxter pumps. You have to run your own history. You have to have your own, you can't use my history. You have to have your own. And why is that? Why is that important too? Why is my history different than your history? So you may have I may have 3 Baxter trained technicians on infusion pumps that can identify issues, or you may have Nurse Betty at your hospital that knocks them off the wall all the time, or doesn't know how to use them, has user issues and stuff like that. It may not be manufacturer based issues or internal component issues, but all that stuff provides data into why you should and shouldn't have something on AEM. Any other questions? Any of that makes sense? I know that was, like I said, that was the very macro, and we could dive into any of this stuff and really get into it. And I love doing that stuff. So I got business cards up here. Please take one. I'll put a few more out there too. If you guys have any questions at any time, shoot me an email. I'll share my policies. I'll share what we're doing. If you can use, we good on time? Oh, we're almost there. 2 minutes. Who is my timekeeper? Are you supposed to tell me 10 minutes? I don't know if I have another. So how do you know if your program is successful? So metrics, I said I'm a data guy. I'm an analytical guy. Numbers don't lie, data doesn't lie. So make sure you're tracking metrics. So especially if you haven't started an AEM program, now's the time to benchmark where you're at. And then you can see, are you introducing more unscheduled work by implementing an AEM program, or are you decreasing work? Hopefully that's what we want to try to get to by introducing that. Same thing with we do that with our budget. How much money have we saved? So that we can always use that to justify with the EOC or whoever, why we should maintain an AEM program. So definitely develop a way to track and trend unscheduled work. We never saw an uptick. We saw things starting to dive downwards. So there you go. My cell phone number, my email. You don't have to take a card. You can take a card if you want. But yeah, I'm here all day too. So if you see me and you want to ask a question, let me know. That makes sense. I haven't done an AEM presentation in a long time, so I kind of wanted to get a touch base too on see where everybody is. And I was kind of under the impression that we'd be about 50-50, and it seems like that's where we are. I think it's a good program. If you do it correctly, you do it right, you do it safely, it would definitely help leverage some of your technician time into other areas that you may need. Cool. All right. Thank you, everybody.